Kind of penultimate question now. So, in terms of the kneecap itself, so what we call patellofemoral disease in the trade. Now, again, you touched on it at the beginning. So sometimes those kneecaps will be replaced, sometimes they won't. I guess that comes down to whether there's actually actual wear and tear in the kneecap, and presumably if there isn't any wear, you don't replace it. But are the outcomes and the approaches, is this like a completely different area in terms of do the kneecaps wear out quicker than the?
Yeah, I think the patellofemoral joint is one of my real areas of interest, and I think even before surgery, it's one of those joints which is not always given that sort of due regard. And in terms of why the kneecaps wear out early in some people and why they don't, it's all due to their biomechanics, and essentially it stems really from the hips, and to do with the version of the hips. Typically in utero the hips are flat, and the femurs develop anteversion. The distal femur then internally rotates, the tibia externally rotates, and that's the normal rotation. So people walk straight, but they've got this rotational effectively that the femurs and tibias are all rotated, and the kneecap will sit. The kneecap, as we know, is a floating bone, so if your femur or tibia are in the wrong position, your kneecap is then going to be rubbing against the wrong surface. So again, we typically see the kneecap as a kind of triangle sitting in a groove, and as long as it does that, it will wear relatively equally. Where that kneecap is flattened, or the whole patella is tilted, you'll get early wear. Where the femur is rotated, that will cause problems with the kneecap sort of sitting on the edge. So all of those things have to be taken into account. In terms of when you come to replacement, how's the decision-making process? I mean, the key, first of all, is obviously data, but also the manufacturer. Certain prostheses, certain companies are what we call patella friendly. They have a very deepened patella groove, and as long as the patient's own patella is good quality, you would try and preserve that. The kneecap is the thing which often is the first thing that fails. That interface between the patella button, let's say, if you're replacing, and the bone is a very sort of generally tenuous fixation. Certain prostheses, certain companies are not so patella friendly. They have a very shallow patella, and therefore you would typically replace the patella in that manufacturer's guidelines, although it's still very much individual. So certainly the company that we use is very is a deepened patella groove, very patella friendly. I try not to replace the patella. If the patella is maltracking clinically, and you can't adjust that on your knee replacement, there's a little bit of movement, a little bit of rotation you can build into it, then you may have to replace the patella. If it's very worn, very striated, sometimes it's so worn, it's so thin, well, actually you're going to cause more problems by replacing it, and even then you would then preserve it. So very, very much individual, but by and large, it's not that I have a rule of thumb: always replace, don't replace. It's by and large, I wouldn't replace unless I feel it's necessary to the patient's mechanics and tracking.
Right. So just so if I understand that correctly, so the default thing would be, are you saying then the prostheses that you tend to use in terms of the trochlear side, you have a is it a cobalt chromium sort of base to it?
Cobalt chrome, nice and deep.
You have a native patella articulating with that cobalt chrome base. Yeah, is that right? But
that's correct.
If then the underside of that patella is quite severely worn, then you put a polyethylene button underneath. Is that right? Underneath that patella.
That's correct. Yeah, and you have the ability to offset it, to obviously bring it up and down. So if someone's got, for example, a patella alta, you can actually then bring that patella down a little bit. You can move it a little bit just to sit better in the
population and kind of the orientation, as you say.
And we're trialing these components. Once you've done all your cuts, you're putting trial components, you're seeing how it looks, and then you can still adjust it after that.
And coming back to one of the questions we asked about the tibial femoral joint, I mean, in terms of lifespan of a patellofemoral replacement, if you did have to go down the route of having that polyethylene button on the underside, is there a kind of rough rule of thumb as to how long they last?
So again, I'm a big fan of patellofemoral replacement for the simple reason, generally, it's a very specific group of patients who have that patellofemoral arthritis, and their tibiofemoral joint is relatively well preserved. So
Mm.
it's almost overkill putting a full knee replacement in these
Mm.
patients.
Mhm.
These patients often have quite significant biomechanical issues, which is why the patellofemoral joint's worn in the first place as an isolated thing, as opposed to the whole knee wearing out. And so, you know, the alignment and those sort of things is really important. But I think I would still be doing, you know, probably, you know, less than 1 in 30 replacements would be a patellofemoral replacement. It's still an uncommon replacement, you know, generally speaking. Or that, you know, patellofemoral osteoarthritis on its own is less common.
Yeah. And then how long would they last? Would you say
I mean, again, you know, the data is slightly less than unicompartmental knees. When we talk about unicompartmental knees, you know, even though it's just one compartment, we're predominantly referring to the medial, you know, compartment, because obviously you can get a lateral uni as well.
Yeah.
But patellofemorals will be less than that, probably 6 or 7 years, is what the NJR states. But again, you know, the issues with both unis and patellofemorals is one of those things where the data is unfortunately skewed, because if you've got these joints in and perhaps patients then come back to, you know, maybe another surgeon, and there's, you know, let's say they're coming back usually because of pain, then it's so easy for that surgeon to say, well, look, let's just take it out and actually put a full knee replacement. So they get, you know, the threshold to revise them is much lower, which is why the data is a little bit skewed.
Right.
Whereas if someone comes back with a painful knee replacement, total knee replacement, you know, most surgeons are going to, you know, say to that patient, well, look, it's not that bad, it's not failing dramatically, let's try and persevere with this. So that's where, you know, just looking at National Joint Registry data doesn't always, you know, help us. You know, it guides us, but doesn't always gives you the answer.
Okay, fascinating. In the cases though, let's say where, you know, I don't know, let's say for example, it's a hypothetical scenario of a patient who's got, you know, patellofemoral disease, it's been replaced, 6 years down the line, it wears out, the medial and lateral compartments are still okay. How easy or how effective is it then just to do a second patellofemoral replacement? Does that ever happen? Or could it happen?
I don't think I've been in that scenario. I mean, it's more one of those what do you call it, sort of a on paper type scenario. I mean, it generally doesn't happen. I think by the time, you know, it's usually, you know, when the patellofemoral replacement, I mean, obviously it depends on how it's put in and the reasons and all that sort of thing, but by and large it's progressive wear in other compartments, so you would generally revise, you know, to a total knee. You know, there was a prosthesis out.
Yeah, so you've gone from a patellofemoral, and then, like you say, there's other where the disease has progressed to maybe the inside and the outside. You've then gone to a total knee, and as part of that total knee, then what you're then revising the patellofemoral articulation as well as part of that total knee.
That's correct. Although you wouldn't necessarily, you know, if the patella button, you know, because generally in a patellofemoral replacement, you are actually replacing the patella, as the name suggests. Whereas, you know, again, it depends which, you know, if the patellofemoral was actually okay, and it's more that the tibiofemoral joint is worn out, you can actually preserve that patella button. You just revise a trochlear, and it's a very, you know, it's pretty simple. You know, revising both, you know, certainly the unis and patellofemoral components that we use, you know, the company that we use, it's actually you know, very minimal bone that's being lost. If you look at the conformis partial, you know, unicompartmental knee replacement, it's almost considered like a resurfacing. You're literally replacing the cartilage as opposed to even taking bone. You're literally, you know, you're just down to the subchondral layer of bone, whereas most patellofemoral will cut a little bit of, you know, cancellous bone. Oxford knee replacement, for example, mills quite a lot. So it, you know, there's pluses and minuses with all these things, as I've always said. But you know, for me, you either patellofemoral or unicompartment. If you're going to revise, you'd probably just go to a total knee replacement.
Okay. So what you just said there, and about the conformis only literally taken off the subchondral cartilage. You talk about on the trochlear side, or the
No, I'm talking. So it's a unicompartmental knee.
Yeah.
So partial, you know, medial compartment knee replacement.
Right.
And literally you're just, you know, you're shaving back down to the subchondral bone. You're then drilling that bone effectively to create the, you know, that sort of bleeding, and then the conformis. So it's very much a curved prosthesis. It's just literally recapping it, as opposed to other partial knee replacements.
But for the patellofemoral specifically, though, you do conformists then do a patellofemoral as well? Is that
No, they don't.
okay?
They do a patellofemoral and a medial sort of knee replacement. Can't remember the name of it, but
Or two together?
again,
Yeah.
yeah, it's a sort of, you know, I guess I think a company called Smith and Nephew used to do one called the Duo. It's a very you're getting into a difficult area because you're trying to treat, you know, use one prosthesis to treat two things,
Yeah.
and sometimes the anatomy doesn't allow you to do that. Sometimes it does, sometimes it doesn't.
Right.
So actually, what people have done is done, you know, what they call the boutique knee, which is, you know, you do a patellofemoral, a separate uni, and then if it need be, a separate lateral uni,
Right.
and thereby you've preserved all your ligaments. But actually, in practice, you know, it's technically very challenging, and you've got more, you know, in my sort of eyes, more to go wrong.
Yeah.
Although people have done that, you know.
Yeah. Yeah. Sure. And just kind of last question really for me, in terms, because again, just homing in to those like the patellofemoral buttons that you mentioned, if they do need to be replaced, is that an easy job, or does that have complications in terms of having to then?
It's an easy job to replace. I mean, you know, that's the thing. It's just, you know, it's a small area. It's a small, you know, they're generally cemented in. Although you do get trabecular metal. Trabecular metal is a kind of a mesh metal where, you know, for an uncemented button or an uncemented prosthesis, it allows bone to grow into this mesh. But generally, most patella buttons in this country are cemented in, so it's relatively easy to take off. The issue becomes once you take all the cement off, how much bone is left. And sometimes, you know, you may need to consider, you know, bone grafting that area or building it up to get the right sort of patella height.
Right.
Obviously, there are revision patella buttons designed to, you know, to compensate for height, offset buttons and things like that. So
Yeah, sure. So it's like you say, it's quite.
but it's generally considered the weak link in most, you know, knee replacements, which is why, you know, I try to, you know, not try, but I, you know, it's by and large, patients have got a good patella, then you would try and preserve their natural, you know, patella.